Usually when we talk about a medical diagnosis, there's this expectation of precision, right?
Oh, absolutely. Like engineering
And
almost.
exactly, like engineering. You fall, you break your arm, they take an X-ray, and it shows that jagged white line. And the doctor just points at it and says, there it is.
Right. Broken or not broken, it's clean.
It's very clean. And I think we crave that. But then you step into the world of psychology, and suddenly that X-ray machine is just, well, it's totally useless.
It is, because it's comforting to have things visible, to categorize things into neat little boxes so the world feels manageable. But mental health doesn't work like that.
No, it doesn't. We're looking at a diagnostic landscape that is incredibly murky. I mean, it's not a broken bone we're trying to find. It's a fractured behavioral pattern.
Which is much harder to pin down.
Much harder.
Yeah.
So today, for our deep dive, we're navigating those muddy waters by looking at the clinical realities dealt with by a group called Coping and Healing Counseling, or CHC for short.
Yeah, and the document we have from them is really fascinating because they operate in this space where the pure logistics of healthcare and very complex human psychology just collide.
Totally. Because before you can even begin to diagnose someone with anything, you have to actually get them into a room, right? Or, well, in today's world, onto a screen.
Right, access.
Yeah.
The physical barrier to mental health care is, frankly, often the most insurmountable one out there.
Yeah.
I mean, you can have the most effective treatment plan in the world, but if a patient lives, say, 3 hours away from a specialist, that plan is purely theoretical. It's useless to them.
Which is why the structural delivery model that CHC uses is so critical to understand right up front. They operate a 100% telehealth practice, and they serve all 159 counties in the state of Georgia.
Think about the geography there. That's massive.
It really is. And it's completely high-pay compliant, so, your privacy is locked down tight. But you can access it from a laptop in a rural farming town, or a tablet in the suburbs, or just a smartphone in downtown Atlanta.
It completely removes the commute.
Yes! The commute, the waiting room anxiety, that whole logistical nightmare of, trying to take half a day off work just to see a therapist.
Because mental health needs do not respect county lines or zip codes. But a reach like that, across a whole state, it really only works if you have the clinical muscle to back it up.
Which they do.
They do, yeah. They maintain a roster of over 15 licensed therapists. So we're talking licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists.
That's a lot of different credentials.
It is, and that diversity means they can handle everything. Individual and couples therapy, family counseling, teen therapy for anyone 13 and older, and even life coaching. They really cover the spectrum.
They handle the heavy hitters, right? Anxiety, depression, trauma, PTSD, grief. And I think this is the part that actually makes it functional for the average person, is how they handle the financial barrier.
Oh, the cost, yeah.
Yeah, because cost is that invisible wall keeping people suffering in silence. But CHC's model really dismantles that wall. The source specifically notes that if a patient is on Medicaid, they have a $0 copay.
Wow, zero.
Zero. And for major insurances, so like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, Humana, the sessions range from $0 to $40.
That is incredibly rare.
It transforms mental health care from a luxury item into an accessible utility. So, okay, let's unpack this. Because providing broad access to care only matters if we actually understand the conditions we're trying to treat.
Right, you need to know what you're looking at.
Exactly. And CHC points out a massive hurdle right out of the gate. We are culturally terrible at defining the problem. Specifically, our vocabulary is completely broken when it comes to one particular word.
Yeah, we use psychological terminology so casually in everyday conversation now. The words just lose their clinical weight.
They really do.
I mean, we diagnose our bosses, our exes, our friends based on a single interaction.
It drives me crazy. And the prime example CHC highlights is the word antisocial.
Oh, people misuse this one all the time.
All the time. We use it to describe someone who is shy. We use it for an introvert.
Right.
Or, we use it for a homebody who prefers reading a book in their pajamas to going out to a loud party on a Saturday night.
Which is just a preference.
Right. Calling a quiet Friday night at home antisocial it's like calling a paper cut a surgical emergency.
That's a great way to put it.
It completely dilutes the meaning of what is actually a very serious, very specific condition. Why do we do this? Why do we water down serious clinical terms to describe totally benign personality quirks?
Well, what's fascinating here is how human language naturally reaches for dramatic labels to describe mild discomforts or, just preferences.
Makes it sound more interesting, I guess.
Exactly. It gives our everyday experiences this false sense of gravity. But the danger, and what CHC is warning about, is that this misuse creates a formidable barrier to actual understanding. When we casually label a shy friend as antisocial, we lose the vocabulary to describe the severe reality of actual antisocial personality disorder, or ASPD.
And the text makes it incredibly clear. ASPD requires a diagnosis by a licensed clinician, not by a frustrated friend, and definitely not by, like, an armchair psychologist on the internet who just watched a true crime documentary.
Right, because a licensed clinician is looking for a rigid clinical threshold. Shyness is a temperament. It's a hesitation to engage socially, maybe due to fear of judgment or just a preference for solitude.
Right.
But antisocial personality disorder operates on an entirely different axis. It has absolutely nothing to do with avoiding parties, and everything to do with how a person views the fundamental rights of other human beings.
So if it's not just being a homebody, what does this clinical condition actually look like in practice? Because the definition CHC provides is stark.
Very stark.
They define ASPD as a long-standing pattern of disregarding and violating the rights of others.
And that phrase, long-standing pattern, it does a lot of heavy lifting there.
Yeah.
Well, we aren't talking about a bad weekend or a temporary lapse in judgment during, like, a particularly stressful month at work. We are talking about an ingrained, persistent way of navigating the world that stretches over years. It usually begins in adolescence and just hardens into adulthood.
And the core of it is violating rights. The specific behaviors listed in the source are intense. They list repeated rule-breaking, lying or conning, impulsivity, aggression, recklessness, and chronic irresponsibility.
Yeah, that list paints a very specific picture.
It does. Let's take lying or conning, for example.
Right.
We aren't talking about a white lie to spare someone's feelings.
No, not at all.
Conning implies this predatory approach to social interactions. It's active, intentional manipulation for personal gain, and it's always at someone else's expense.
Because it's transactional. To someone with ASPD, other people are viewed not as human beings with intrinsic value, but as instruments to be used, or obstacles to be removed.
What?
And when you combine that transactional view with the aggression and recklessness mentioned in the text, you get a psychological profile of someone who operates completely outside the social contract that the rest of us just implicitly agree to.
Okay, so here's where it gets really interesting. The hallmark of all these behaviors, the thing that ties the lying, the aggression, and the rule-breaking together, is that it happens according to the text with, quote, little remorse afterward, unquote.
Yeah, that absence of remorse is the linchpin of the entire disorder.
Because, think about it, if I make a normal mistake, say I cross a boundary with a friend, or I act recklessly and accidentally hurt someone, I realize it, my stomach drops, I feel terrible, and I apologize.
Right, you feel guilt.
Exactly. The guilt forces me to try and make it right. But with ASPD, it's not just crossing a boundary line. It's like driving a bulldozer over the boundary line, flattening everything and everyone in its path, and genuinely not acknowledging that the line ever existed in the first place.
That's spot on.
You look back at the wreckage you just caused, and you just shrug. The internal emotional consequence does not exist.
That bulldozer analogy captures the collateral damage perfectly. Let's analyze what happens when you combine a complete lack of remorse with high impulsivity.
Okay, yeah.
Because impulsivity means a person is going to act without thinking of the consequences. And the lack of remorse means that once those negative consequences inevitably happen to someone else, there is no internal emotional brake pedal to stop them from doing it again.
There's no guilt to course correct the behavior.
Exactly. The standard social feedback loop is fundamentally broken. Most of us learn not to be chronically irresponsible because the guilt of letting others down feels awful.
Right, we avoid the reckless behavior to avoid the negative feeling.
Yes, but without the capacity for that guilt, the reckless and aggressive behaviors just loop endlessly. It's a terrifying mechanism when you realize the person causing all this harm is probably sleeping perfectly fine at night.
Which naturally leads to the fallout. Because ASPD involves such high levels of recklessness and this constant rule-breaking, it creates a causal bridge to secondary issues.
Things that kind of hitch a ride with the primary disorder.
Right. And CHC notes two specific demographic and behavioral details here. First, ASPD is more common in men. And second, it very frequently goes hand in hand with substance use.
And those two data points are crucial for understanding the full, complex clinical picture a therapist is looking at when a patient logs on for a telehealth session. You rarely see ASPD in a vacuum.
I want to push back on that substance use link, though, or at least ask a question about it.
Sure.
Based on everything we just unpacked, the recklessness, the impulsivity, the chronic irresponsibility, is the substance use just another symptom? Like, is drinking or using drugs just another way for this person to break a rule and act recklessly?
That's a really good question.
Or is the substance use an accelerant that makes the underlying aggression and lying fundamentally worse?
Well, if we connect this to the bigger picture of clinical treatment, the substance use often functions as a massive accelerant, regardless of how it originally started. CHC specifically positions treating the addiction as a crucial wedge that, quote, opens the door to change for the underlying personality disorder.
So it's basically locking the bad behavior in place if it's untreated.
Think about what substances do to the brain, even a typical brain. They impair judgment, they decrease inhibition, and they increase impulsivity.
Right.
Now, apply those effects to a brain that already has a severe deficit in impulse control and a complete lack of empathy.
Oh, wow. That's a recipe for disaster.
It strips away whatever minimal, fragile restraint the person might have originally managed to develop. You cannot possibly address a deep-seated, long-standing pattern of disregarding human rights if the patient's brain is constantly flooded and destabilized by chemicals.
So the substance use isn't just a side effect a therapist can ignore while they work on the personality issues.
Not at all.
It's a compounding factor that has to be neutralized. You have to put the fire out before you can rebuild the house.
Exactly. Treating the addiction drives a wedge into the chaos. It creates a baseline of sobriety. That sobriety doesn't cure the antisocial personality disorder, obviously, but it creates just enough space, just enough stability to begin the actual heavy lifting of addressing the behaviors.
And that heavy lifting brings us to the hardest part of this whole discussion, which is treatment. Understanding that this disorder is a deeply ingrained pattern, complicated by substance use, and a profound lack of remorse, how does a clinic actually manage it?
It's not easy, and CHC is remarkably blunt about this reality.
They really are.
Which is necessary, because in mental health, false hope can be just as damaging as no hope.
They say it straight up. ASPD is one of the tougher conditions to treat. Anyone promising a quick fix or like a sudden emotional awakening isn't being straight with you.
Right.
But I have to challenge the viability of therapy here entirely.
Okay, let's hear it.
If the entire disorder is defined by a lack of remorse, chronic rule breaking, and a predatory instinct to con people,
Yeah.
how can a therapist possibly get through to them? If a patient doesn't feel bad about their actions and they actively manipulate people as a default setting, wouldn't they just manipulate the therapist?
Oh, absolutely.
It seems like a therapy session would just be another arena for them to run a con.
That is the exact trap. And it's exactly why traditional, emotion-focused talk therapy often completely fails with ASPD.
Okay, that makes sense.
If a therapist sits on a couch and tries to explore a patient's hidden feelings of guilt or empathy, they are digging for gold in an empty mine. The patient will quickly figure out what the therapist wants to hear, they'll mimic the appropriate emotions, and essentially con their way through the treatment.
They'll just play the game. So how is it not hopeless? Why even bother treating it?
Because you shift the entire goal of the therapy. The approach CHC highlights doesn't rely on emotional breakthroughs. It relies on, and they call it this, structured therapy targeting behavior, impulse control, and substance use within a clear and consistent framework.
Let's dig into that phrase, clear and consistent framework. What does that actually look like in practice?
Well, it looks like building an external conscience for someone who lacks an internal one.
An external conscience.
Yeah. You don't focus on making them feel emotional remorse, because that capacity might simply be missing. Instead, you focus entirely on concrete actions and consequences. The therapist establishes absolute, unbreakable rules for the therapeutic relationship.
And what if they break them?
That's the key. The therapist helps map out the absolute, unbreakable consequences of the patient's behavior in the real world. You are systematically targeting the impulse control.
So you're making the rules so rigid that they can't bulldoze over the boundary line without hitting a literal concrete wall of accountability?
Precisely.
It's not about making them feel bad about speeding. It's about making them realize that if they speed, the car gets taken away. Every single time.
It's behavioral modification through practical management. You are teaching them how to operate within the social contract out of self-interest rather than out of empathy.
Because that's all they respond to.
Right. You show them that reckless behavior and aggression ultimately result in outcomes they do not want, like incarceration, loss of resources, or loss of freedom. It's a highly clinical, highly structured containment strategy.
So what does this all mean? When we tie it all back to where we started, this is exactly why a structured, highly accessible environment like coping and healing counseling is so vital.
It's the perfect match for the problem.
It is.
Yeah.
We talked about their telehealth model serving all of Georgia with $0 to $40 copays. But the logistical consistency of that model, the secure digital platform, the set appointments, the highly trained LCSWs, LPCs, and LMFTs that directly provides the rigid framework needed for these tough cases.
The structural delivery of the care aligns perfectly with the clinical strategy required. Because a highly manipulative patient needs a highly stable, boundaried environment, one managed by professionals who know exactly how to maintain a clear framework without being drawn into a con.
It's logistics meeting a very intense clinical need. And for anyone listening who realizes that they, or, perhaps a family member, requires this kind of structured, specialized care, the accessibility is already built in.
You don't have to drive 3 hours.
Exactly. You don't have to fight through out-of-network billing nightmares. CHC is reachable online at shicktherapy.com, through email at support@shicktherapy.com, or by phone at 404-832-0102.
Because understanding the mechanics of a disorder like ASPD is only practically useful if you have a pathway to professionals who are actually equipped to manage it.
Very true. Well, as we wrap up this deep dive, we've covered a lot of ground today. We've looked at how misusing the word antisocial blinds us to a severe clinical reality. We've unpacked the devastating impact of impulsivity combined with zero remorse, the accelerant of substance abuse, and the absolute necessity of rigid behavioral frameworks to manage it all.
But, there's a lingering thought here that goes beyond just the clinical definitions.
What's that?
Well, we spent a lot of time discussing that external scaffolding, right?
Yeah.
How therapists use structure and consequences to modify actions. But it raises a profound, almost philosophical question for you to ponder long after you finish listening to this.
I love a good philosophical question. Let's hear it.
If a core symptom of antisocial personality disorder is a fundamental inability to feel remorse,
Yeah.
how sustainable is that behavioral framework? It forces us to question the true nature of human change. Can we truly modify someone's behavior permanently when the internal mechanism of emotional empathy is completely missing? Or are we just indefinitely managing a risk?
Man, that is a fascinating paradox. It really is like stepping into those diagnostic muddy waters we talked about at the start of the show. The x-ray machine is broken, the picture of human empathy isn't clear, and we just have to rely on entirely different tools to build a safe structure in the dark.